Our speaker is Dr. Osama Haji. Dr. Haji, he's a senior attending consultant rheumatologist at Muasa Dammam Hospital. He's an associate professor at Ain Shams University in Cairo. Dr. Haji will entertain us for the coming 20-25 minutes about Olumiant, and the title of his presentation is Disrupting the Standard of Care. The floor is yours.
Yesterday I'm walking, I'm very astonished. What is that? What a change happened in this area. If this be applicable to rheumatoid arthritis, that after 10 years there will be everything will be changed upside down, we are waiting to see more. Yes, we are a lucky generation in the field of rheumatology. We have a lot to do, we have a lot to diagnose, and we have a lot to treat our patient. So I will make our title just as much. It's not working, sir. Excuse me. Our title today is Rising Bar in Rheumatoid Arthritis. Yes, it will be sponsored by Eli Lilly Company. I will make it is by baricitinib. Yes, it's not related to Eli Lilly Company. Everything here is related to my own opinion. So this is rheumatoid arthritis.
Could you check the? I think there's a problem with the sound.
I will be. Yes. Yes. I will be on time. Super time. Yes, this is rheumatoid arthritis, the same. Everyone say it is mediated by T cell, it is mediated by B cell, it's mediated by cytokines, mediated by JAK, it's early, it is innate. Everything is right, but still we are missing the whole picture. We are making macro evaluation for the patient with rheumatoid arthritis. Lucky enough, we have 11 biological therapy. But if looking to this one, that you can see that is still the remission rate is still beyond the expectation in all this. This is not the head trial, but the most famous one, Aspire, Premier, Comet, Agree, and the Image trial with different biological agent. Still we are missing. The point is what we achieve. In the patient which is methotrexate inadequate response, about 70 to 80% of the patient did not achieve the good response for us, which is ACR 70. But the point is still, if the patient is biological inadequate response, 80 to 90% of the patient did not achieve ACR 70. So we have to do more work. We have to have more agent to achieve our target, which is remission or low disease activity in daily clinical life. We are lucky that we are now working intracellular. We are not working outside the cell. We are not working in the level of the receptor. We are not working on the level of extracellular. We are working inside the cell. The most important and developed one is JAK-STAT, which is transmitting on transduction of the signal from outside the cell to the nucleus to make activation of transcription factor of all cytokines. Lucky enough, the TNF is not mediated by JAK, so we have opportunity here to act through JAK, or we have other opportunity to act through TNF. Please, this slide is the future of us. This slide can change the paradigm treatment of rheumatoid arthritis. Forget everything and here. After the patency is finished for the JAK, there will be a cheap medication, even cheaper than methotrexate. At the time, after 5 to 10 years, we can say we have to start by methotrexate or we have to start by JAK. So to have experience and to have safety and efficacy data, it will be great. For biologic, yes, it is effective, but it is high molecular weight. But for JAK, it is small molecular weight, it is oral, it is not biological. So please, we have to respect that we should not tell our patient this is biological therapy. This is the second generation of methotrexate, which is target synthetic intracellular signal or demand. The point here that we have baricitinib, which is rapidly absorbed, highly selective JAK1 and JAK2. By the way, I'm okay. Within a few years, there will be a 20 JAK in the market. 20 JAK. We have 2 now, and the third is coming. We have 20 JAK on the way. For different rheumatic disease, yes, there's a clinical trial for SLE, more rheumatoid arthritis, for ulcerative colitis, for atopic dermatitis, for allergic dermatitis. Everything is there. So the coming era, at least 5 to 10 years, it will be related to JAK. But the most interesting is that the short half-life. For me, it's practical for younger ladies that she can expect to be pregnant at any time, so you can easily modify the treatment. If you are preparing for surgery, you can easily manipulate. It is easily flexible to be treated in daily clinical life. What we have for any JAK coming or now, there must be a 4 clinical trials. So it is not a clinical trial, it is a program. What does it mean? You have to have a clinical trial for methotrexate naive, for biological naive, for biologically inadequate response, and for long-term safety. That's why it will be applied for all of them. But the point for baricitinib, we have 4 clinical trials, which BEGIN trial, BEAM trial, BEACON trial, and for BELD trial. The most interesting that you have all case scenario. What does it mean? You have scenario if the patient methotrexate naive, if the patient CS demand, if the patient failed biologics, or the long-term safety data for all of this. But for me, this is the most interesting slide. Why? If you're going back to TNF, which Premier or the TEMPO trial, you remember that biological agent achieve from 40 to 50%. 40 to 50%. All of them cannot kick methotrexate. All of them have the advantage to be biologically active with the aid of methotrexate. That's why combination for TNF is the rules. But here, for the first time, that is DMARD naive, we're achieving 77, we're achieving 78. So it means the patient can achieve more with a short period of time. This is the advantage of BELD. The BEAM will come to BEAM later on, but what is the most difficult patient? Here, it is a DAS. Again, here, within 24 weeks, the patient is achieving 57 or 60. It is easily that you can detect within few months if your patient responds to JAK, baricitinib or not. You can decide at that time to continue or to decrease the dose, whatever it is. It is easy to be applicable in daily life. The most hard patient is biologically inadequate response. What does it mean? Patient taking a lot of TNF and still the patient not responding. In this clinical trial, they are randomized the patient to placebo, baricitinib 4 milligram and 2 milligram. What they found, within a short period of time, which is 12 to 24 months, the patient achieving a good response. 50%, if you are going to another clinical trial, you will see the response between 20 and 30. Here the response is 50. Yes, it is not head-to-head trial, but within very short period of time, which is 2 weeks, the patient is getting response. What about the other factor? Whatever you are evaluating your patient with CDI or HAC, ACR20, or DAS-CRB, still, it is active within short period of time. 2 and 4 milligrams is effective in comparison with placebo. The most interesting in this, I'm not talking about baricitinib by name, but for any JAK coming, there must be, again, 4 clinical trials. One of them must be against the standard of care, which is adalimumab. Worldwide, up to the moment, we have 4 clinical trials. One is the standard, and another is strategy. This is for one, for tofacitinib. For abatacitinib, the same company. It is compare and select. And for BEAM, in these 2 clinical trials, it is non-inferior. What about BEAM, which is baricitinib against adalimumab? If you can see here in a very clear way, methotrexate inadequate response, again within 12 weeks, 70% of the patient achieve. If you are comparing here with 61, yes, it is. But if you are concentrate with the plus here, that versus adalimumab, you can achieve a good response here as regard ACR70, as regard ACR50, ACR20. So practically speaking, you can achieve faster or slower. The advantage of JAK in daily clinical life that it is fast medication. It is not like methotrexate. It is not like leflunomide. It is fast acting. What does it mean? Within short period of time, which is few weeks, Still, it is significant as regard ACR 20, 50, 70, whatever it is, against versus adalimumab in all of them. What about the ACR components? Swollen joint count, tender joint count, for just sake of time, physician global assessment, patient global assessment, significant difference against placebo. Baricitinib is more effective within a short period of time. By the way, select and compare, the same company, they found that JAK abatacitinib is superior to adalimumab. So the JAK is coming with the way, and it can change the paradigm for all medications that we have. What about the DAS? DAS 28, if you can see in a very clear way that it is effective as regard 12-week, 24-week, and 52 versus adalimumab and versus placebo. So it is non-inferior, not non-inferior, it is superior. What does it mean in a very practical way? If two of them is like this, it means non-inferior clinical trial. But if it is like this, means baricitinib is more superior than adalimumab. It is difficult statistical point, but it is superior to adalimumab. What about simplified or clinical disease activity? It is comparable with placebo. Again, the figure is great, 51. 57, 57, comparing with 50. What about the component radiological? Radiologically, both of them are identical to each other. What does it mean? If you are comparing with the long here, all the figure is nearly identical between adalimumab and JAK as regards radiological progression. This is the most interesting. It is published in February 2019, last month in American College of Rheumatology official journal. What they are saying a practical manner. If the patient was 4 milligram responding, why not to increase the dose to 2 milligram and see what is the response? What they found 1 out of 5. It means 20% there is disease activity. If you compare it with TNF, it is more there, but here it is 20%. What if you are increasing the dose again to 40%? 2/3 of the patient that achieve disease activity, again, control disease activity. So the advantage for baricitinib that you can manipulate the dose according to the patient response, according to perioperative status, according to adverse effect, it is easy to be manipulated daily life. I like this slide. Why? Because we have to concentrate on the last one, which is loss of function, which is the patient-reported outcome, which is BRO. All the clinical trials in the future will be based on Apple or Google. They are based on what the patient feels in real life, not in the physician. That's why the patient-reported outcome, again, one of the great advantage for baricitinib. As regard what? Again, going back to BEAM clinical trial, you can see the duration of morning stiffness, severity of morning stiffness, worse joint pain, worse tenderness. It is significant difference between baricitinib and adalimumab within what? Within a very short period of time. In TNF, you can use TNF in an empirical way, as we are doing. But to check the response, you are taking about 3 to 6 months, right? 3 to 6 months to check the response for TNF. Then you can change the medication. But here, you can use for 3 months. If the patient not responding within 3 months to JAK, it is not effective, you can change. That's why our goal is to achieve, but in a very fast way, not like before. So the FDA approved 2 and 4 milligram. European Medical Agency approved 2 4 milligram. And FDA approved the smaller doses, 2 milligram, the same like tofacitinib, which is approved by 5 BID, 11 milligram XR, whatever they are choosing to choose the lower dose. But EMA and the Saudi FDA approved 2 and 4 milligram. Again, to be honest, this is abstract presented in the last meeting in Chicago, November 2018. It is not yet published, but it is pending, or to impress that. What about the safety, which is the most important? What they are taking all baricitinib long-term evaluation, and they found what? This is the most important one. What is that? By the end of February 2016, Joseph Smolin published in 2018 what is the status of long-term safety for up to 6 years or 7 years. In April 2017, this is a clinical data by Genevieve et al. Presented in EULAR, and they found what is the most important dangerous DVT. You can check between here, 34, 42, the incidence is 0.5, the same that we have in patients with rheumatoid arthritis. What about any other infection? Yes, it is common. It's as compared by biological agent. But the most interesting one is herpes zoster, and we'll take it later on. Herpes zoster here, 3.2, 3.3. So herpes zoster, due to inhibition of gamma interferon, it is there as a side effect. If you are comparing 4, 2, and 4, it is the same as regard the DVT. 3, 4, there is no significant difference at all between both of them as regard the long-term safety. What about the serious infection? It is around 3, or the whole is 2.2, the same like TNF. Any biological agent, it is expected. But the advantage for JAK is that if the patient has infection for any reason and you can stop, within few days, the medication is not there. The half-life is 1.5 hours to reach the maximum. Within 12 hours, JAK is not there. JAK is a short half-life. That's why you can manipulate. But if I'm giving single monthly injection, it is hardly to be controlled, that immunosuppressive status of the patient. What about infection? In a very clear way, herpes zoster, it can be modified, but in baricitinib clinical trial, it is not severe, there is no complication for it, and it is easy to be controlled. Even if it is herpes zoster, you can stop and treat the patient or vaccinate the patient pre-treatment. So what about malignancy? There is no signal at all as regards the malignancy by time period, which is more than 145 weeks. This is again the new clinical trial, which is the cardiovascular safety. The cardiovascular safety by Taylor from UK, they are making the long-term assessment, which is post-hoc analysis of the patient with long-term as regards cardiovascular. Cardiovascular here, there is no difference at all. It is stable either. The cumulative incidence rate by all group, it is here about 0.5 for the MACE major adverse cardiovascular events. It is here the same. So there is no signal for cardiovascular risk. What about arterial thromboembolic? Just to concentrate for the sake of time for the last one, again around 0.5, here around 0.5. By the way, patient with rheumatoid arthritis is liable to be thromboembolic. Why? Because of inflammation, because of risk factor, because of long-standing disease. But it is comparable or slightly increased. We will see what will happen. This is the vascular thromboembolic embolus. Here it is the same 0.5. There is no signal. But this one, the most interesting one, all the headache as regard thromboembolic for all JAK come from this one. The patient with placebo has no adverse effect, but the patient with active medication, which is Barry, has. But when they are shifting the placebo to active medication, there is no side effect as regard vascular thromboembolic event. So it can happen by luck. We are waiting for further evaluation in the future to answer this in a very clear way. But for all baricitinib, it is around 0.5, so it is the same like rheumatoid arthritis. What is the most critical patient that can develop DVT or pulmonary embolism? They are making analysis by Taylor. It is pending for publication, arthritis rheumatism within few months. All these factors, they are making a correlation. What is the most interesting one? This one. That the patient with a history of DVT, pulmonary embolism, this is the highest risk factor. Don't give any JAK to any patient with a history of DVT in a very practical, honest way. Right? All patients with JAK and previous DVT, JAK is not allowed to give. It is simple. Why? Because it is a class effect, most probably. COX-2, it is increase, of course, BMI, obesity, little, and age in older age population. So the most important, don't give JAK or baricitinib for the patient with a past history of DVT. So the conclusion that during long-term follow-up, incidence rate was similar between doses, consistent with time, and similar to what's published in RA. So what is the most dangerous signal? Don't use JAK. Don't use JAK if your patient has any one of them. Total lymphocytic count is 500. Neutrophilic is 1,000, and don't give is the hemoglobin is 8. This is for all JAK. This is a rule of thumb for all of them. If the patient develops neutropenia, if the patient develops lymphopenia, if the patient develops any side effect, you can hold the medication for a short period of time and you can start. The advantage for baricitinib that you have 2 and 4 milligrams, you can manipulate in a very easy way. So this side effect, what happened? Common, it is happening in 1% of the patient in clinical trial. This picture from my city, Cairo, Although I am here in Saudi Arabia for more about 18, لا أنا 18. Yeah, 2 minutes I will be. This is the last few slides. So we are crowded. I can challenge any one of you, senior, and all the brothers like Dr. Rams, like Dr. Sulaiman. This is the way we are cooperating together. We are transparent. This is no clear answer when and how to use any one of them. There is no clinical trial to say this is more advantage except in a beam and select and compare clinical trial. EULAR answered this one in a very practical way. What they are saying in a very easy way that if the patient has prognostically unfavorable factor, what does it mean? RF positive, ACPA positive, patient with erosion or not responding to any medication, this is the most dangerous patient, and you have to treat this patient in a practical, aggressive way. You can try methotrexate, but if failed, here you can use jacqueline and biological, all of them on the same level. Why I didn't choose ACR? Because ACR is 2015 and this one is 2017. We are waiting for the new version of ACR guidelines this year that to see which of which. But for EULAR, by the way, EULAR bought jacqueline before approval of a European Medical Agency as effective medication. What? 1 minute only, right? If the patient is failed, you can try another whatever, you can change all of them. Remember, we have 13 medication, 2 JAK, and the third on the way, and we have 9 biological agents. The aim is to achieve low disease activity or remission. That's what we have. So our bottom line here, and the most interesting one, is this one. I call it ladder, like WHO, pain treatment. The first is methotrexate. If the patient failed methotrexate or failed combination, the second either to use JAK, baricitinib, or to use biological therapy. This is the way that we should treat our patient in daily clinical practice. What is the advantage of JAK? The advantage of JAK is this one. It is oral medication. Remember, that's oral. What does it mean, oral? The patient can take it wherever in the kingdom. We are not rheumatology in the big city. We are not rheumatology in Jeddah or Riyadh or Dammam or Medina. We are treating the patient all over the kingdom. The patient may travel about 600, 500 to come to see you in a visit. You will give biological treatment to be kept, to be given in a good way. The patient has what? JAK's count goes where the patient goes. It is simple, easy way to be kept in the bag wherever the patient is traveling. It is simple as that. JAK means that immunogenicity is not there. It is not lost on time. Again, JAK, it is flexible dose baricitinib, 2 and 4 milligram. You can start by 4 for active disease, then control to 2. If the patient has relapse, you can manipulate both doses to control the disease as much as you can. By this, I wish I'd be on time. Thank you for time and attention.
Thank you, Dr. Haji. We'll take 1 or 2 questions just for the sake of time. تفضل دكتور. Can we give the mic? Can we give the mic, please?
Sorry. أنا آسف إن أنا هقف بس ما كان ينبغي لي أن أنا أقعد قدام أستاذي يعني. تفضل.
Thank you very much for this elegant presentation and explanation. It's very educational and really very easy to understand. The point now, as you said, you can have the JAK in your pocket. That's true. But you know, when the era of biological treatment came to action, then we have been fortunate to have these to treat our patients. But as you know, there is many mechanisms, one from the receptors, from the antigen to the receptors and the coupling, and then when you deal with the receptor, the cell receptors issues, and then the JAK inside the cell. So no one, or we cannot say that all the pathogenesis of the rheumatic disease is the same for all patients.
Yes.
So some of the biological treatment will work for this patient, but not for that patient. Then what do you think the plan to start with? using biological for treating the patient, should we use all JAK and ignore other agents, or we have to try the other biological treatments that targeting TNF, and then if they fail, we go to the JAK? And do you think sometime we will be in a position to use both biological treatments to treat patients, or this is very dangerous?
Yes, let us start by the last one. Combination of JAK and biological therapy is contraindicated because the risk of infection would be increased, the side effect would be, so we have to choose between both of them, either biological therapy or either JAK, like baricitinib. This is the last one. As a mechanism of action, yes, all of them is acting inside, but there is no magic solution. If you can see that in all clinical trials for TNF, the response is about from 40 to 60%. With time, it will be decreased to 50%. So 50% is responding and 50% not responding. That's why we can start with which arm, whatever you like. But the advantage in Saudi Arabia that if you are treating that child being buried, the patient may ask you at any time, I am planning for conception. If you are using methotrexate, it will be difficult. You have to spend at least 3 to 6 months to stop the medication or to give folinic acid and let her to be pregnant. But for JAK, baricitinib, you can miss one period, the next one, she's allowed to be pregnant according to the anna or the whole. Yeah. Yeah. 1 minute. One second. So between both of them, you can use biological therapy or JAK. The advantage of JAK, it is fast mechanism of action. It's act within few weeks. After 3 months, if not responding, you can shift. My own dream to patients with rheumatoid, my own dream in the field, that we should be like our colleague in oncology. What does it mean? Sequential therapy. What does it mean? It is JAK, it is TNF. Either which protocol will be, the future will tell us we are in need of protocol, we are not in need of medication anymore. We have to have a protocol which patient will be treated in a proper way. And thank you for the question.
Thank you so much.